Hello, my name is Dr. Kristen Schuyten, and I am pleased to present our most recent research endeavors investigating the development and future implementation of the progressive return to performance protocol to support post-concussion management among university performing arts students. Let's meet our research team. I am Dr. Kristen Schuyten, a physical therapist and lecturer at the University of Michigan School of Music, Theater, and Dance in Ann Arbor, Michigan. Dr. Allyssa Memmini is an assistant professor of athletic training at the University of New Mexico in Albuquerque, New Mexico. Dr. Paola Savvidou is a wellness program manager and lecturer at the University of Michigan School of Music, Theater, and Dance in Ann Arbor, Michigan. Drs. Kristen Schuyten and Dr. Paola Savvidou do not report any conflicts of interest. Dr. Allyssa Memmini has received funding from the National Athletic Trainers Association Research and Education Foundation, in addition to various speaker honoraria and travel reimbursement for talks given, and supports projects funded by the U.S. Department of Defense and National Collegiate Athletics Association. This work is supported by University of New Mexico Research Allocations Committee grant. During today's lecture, I will define concussion and typical symptom profiles, common mechanisms of concussion in the performing arts, and post-concussion management. My colleague, Dr. Memmini, will wrap up today's lecture with how the progressive return to performance protocol was developed, followed by future project initiatives to investigate implementation procedures in higher education. A concussion is an injury to the brain that results in temporary loss of normal brain function. Medically, it is defined as a clinical syndrome characterized by immediate and transient alteration in brain function, including alteration of mental status or level of consciousness that results from a mechanical force or trauma. However, not all concussions can result in a loss of consciousness, and this does not have to be present in order for a concussion diagnosis to be confirmed. Sport-related concussions, or SRC, is a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. This initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation affecting the brain. Sport-related concussion then follows the same definition, but it is a concussion that occurs specifically during sports and exercise-related activities. Performing arts practice, training, performance, and competition would all fall under this as well. Signs and/or symptoms of concussion may, but may not always present immediately and will peak within the first 48 hours after the head injury. The image gives a great visual for the many different symptoms that can be present after a concussion. An individual may have one or many of these symptoms, with each individual and their expression of these symptoms varying depending on the mechanism of injury, the intensity and the position of the force, and other comorbidities, including past history of concussion. So how do concussions in performers happen? What is their mechanism of injury? In dance, figure skating, and gymnastics, it can be from collisions with others through choreography, slips, and falls, resulting in head contact with the floor, the ice, or apparatus. Ice is a low-friction surface. An unsuccessful attempt of the upper extremities to stop a fall may result in a head injury. Figure skaters have a unique situation during spins as well, where they can reach up to 2.2 Gs of force, resulting in microtrauma to the brain. They often actually put small periods of relative rest in the program after these spins, so the skater can recover from the forces and the effects that they may have on their vestibular system. Similar to that in dance, the repetitive whipping of the head and the neck, known as hairography, like the picture here, can lead to microtrauma as well as being considered in dancers. Marching music and musical theater have unique potential causes with impact from props and instruments. Specific to marching musicians, their eyes are fixated on the drum major or conductor in order to maintain their timing with the music and with their marching. Therefore, they rely on their peripheral vision to help know where they are on the field, which poses a unique risk for any type of collision. When we think about the various types of students on university campuses, most fall under the two following categories. One, varsity student athletes, and two, general or non-athlete population students. Student athletes have access to a multidisciplinary team, which oftentimes is led by an athletic trainer, a team physician, and clinical input from other specialists, either in-house or local. General population students must seek help from various entities, many of which have inconsistent recommendations to support students in the classroom after a concussion. Regardless of the student type, there is a lack of communication between medical and academic teams. Medical teams rely on the instructor's guidance to modify their coursework as they see fit, and many therefore may provide vague or infeasible academic support recommendations. Academic teams strongly rely on discharge documentation and do not have the education to know how concussions can negatively influence academic progressions. As a result, it puts the student in the center of trying to communicate for both sides, which can put them in a very vulnerable position, especially post-concussion. Varsity student athletes are protected under the NCAA model at present. Complying institutions must follow the concussion safety protocol checklist, which includes specific guidelines on how to support students. Specific return to learn. There are key strategies that clinical teams must follow that are outlined in that policy. However, this management plan is not available for non-athlete or general population students. Over the next few slides, I'll describe the four-step RTL, or return to learn strategy, that can be employed in primary through post-secondary settings, which could be a good starting point for clinicians to support students during their recovery. Here is the return to academic strategy that was published in 2024 with the NATA, the National Athletic Trainers Association, bridge statement, which was adopted from their most recent International Concussion in Sport Group consensus document. The progression includes 4 key steps to assist students with safe progression back to their learning environments. Importantly, the RTL, return to learn progression, can occur concurrently with the return to sport progression, but students should be fully RTL, return to learn, before their return to sport. Beginning with stage 1, we want to encourage students to engage in ADL's activities of daily living, such as light walking, social activities that do not worsen their symptoms, and limited screen time. If you are a clinician, I strongly suggest you to recommend that patients use additional lights in their rooms when using small electronic devices rather than doing so in a dark room. By stage 2, students should gradually increase their cognitive activities like light reading, performing math problems, or performing computer-based tasks outside the classroom setting. You can then gradually consider increasing screen time if it's required by their curriculum. By stage 3, students should be returning to school part-time. Additional recommendations during this stage include allowing the student to leave early to avoid busy passing periods, moving their assigned seat to the front of the room to avoid straining their eyes, providing printed out copies of their lecture notes, and/or assigning a note taker during their class. By the 4th stage, students should be back in the classroom setting and weaning away from their academic supports. Encouraging students to work with their teacher or instructor to modify academic supports based on the curriculum is key. 504 plans, or IEPs, individualized education plans, may be needed to establish for students in K through 12 education with persistent symptoms. It should be noted that not all students required academic supports. However, those that will not always have to start at stage 0, so we're at the very beginning, and many will not have to have any school absences. The entry point for the return to learn progression should be dictated by the patient's symptoms and functional status. While the Return to Learn protocol offers a stepwise approach to assist students with returning to their learning environment, it does not adequately provide guidance for instructors of more movement and/or performance-based disciplines. There is a complex interplay of multiple sensory systems such as sight, vestibular, and auditory systems, and variance in the movement patterns, styles, and even the names within the performing arts disciplines make it challenging to develop a standardized and research-based approach in return to performance. Also, the lack of providers and researchers knowledgeable in the performer's specific needs and movement demands further this difficulty. Regarding touring and traveling for the performers, concerns like adequate and consistent diet, training, and exercise, postural stresses with sitting, carrying equipment, things like time zone changes, even self-medicating, all can affect the recovery from head injury. Looking at a culture of reporting, are these performers supported, or are they worried that they will lose their role, their position, their job if they report having a concussion? We see the performers continuing to try to push the envelope for performance and training. And for our younger performers, sometimes before they have the foundational strength and capabilities to try these more challenging tasks. Now we look at the return to sport strategies. This image depicts the International Concussion in Sport Group 6-step strategy to assist with safely progressing patients back to sport. This is what's available out there for our athletes. In steps 1 through 3, patients will progress from daily activities of living that do not exacerbate symptoms through either light aerobic exercise and then eventually performing individual sport-specific exercise. Importantly, the patients must not have more than a mild exacerbation of symptoms, no more than a 2-point increase in symptoms in order to progress through the protocol. If their symptoms worsen, they are to return to the previous stage to see what they can tolerate. The second half of the protocol may be initiated once the patient has had resolution of any symptoms, abnormalities in cognitive function, and any other clinical findings related to their current concussion, including with and after a physical exertion. In steps 4 through 6, the clinician will work with the patient not only to increase their physical preparedness, but also their mental training too. For example, each stage includes a cognitive component to assess. By step 6, the patient should be fully returned to physical activity and/or sport without any modifications or supports. However, despite these advancements in concussion management, their recommendations are not possibly specific enough to address the unique demands of our performing arts students. At the post-secondary and college and university level, carrying on to the professional level, our students demonstrate movement and environmental demands, including the following. For our dancers, in addition to inversion, partner stunts, and navigating several styles of dance, many performances have props like masks that can blind parts of their visual field, making collision and impact a potential for head injury. For theater, drama, and musical theater, the stages may be fixed or movable depending, also changing in the floor height, scene changes, floors that have tracks in them for easy shift changes, stage weights and ladders, elevated platforms, stage fog, pyrotechnics, and even performing close to the stage. Costuming can put a strain to the shoulder, neck muscles that support the head, the muscles of respiration, headdresses, masks, wigs, and even headgear that can all change the center of gravity for the performer. In fact, in the 2009 Tony Awards, Bret Michaels from the 80s rock bands had got in the way of a piece of scenery as it descended, which caused facial fractures and head injuries. Music includes specific postures that are required to hold and perform their instrument, and even though they are at a decreased risk during their practice and activity, their ability to integrate their sensory systems and posture concerns that may be exacerbated post-head injury are a concern. For marching band, they have an increased risk of collision with instruments and implements of all shapes and sizes. And we look at auditory sensitivity and donning earplugs. Attenuating to high frequencies too much, especially if they are not custom fit, musicians may not want to wear them, which may hinder them being able to play with those auditory sensitivities.
Thank you, Dr. Schuyten. I'm going to go ahead and take over from here. As Dr. Schuyten had kind of set up the stage really nicely for the problem or the big, research question, we wanted to dig into the literature to get an understanding of what is really out there in terms of post-concussion management for our performing arts students, particularly in that post-secondary or university or collegiate setting. And when we first kind of joined forces to create this research group, we are really, again, interested in understanding what's out there and maybe how can we modify it. So when we do a quick search, this was conducted a couple weeks ago, we can see that there is a huge dearth of literature or lack of literature in regards to not only concussion management, but really any type of concussion studies, ranging from concussion education and prevention all the way through post-concussion outcomes. And we can see here that even with the most recent PubMed search that we did, we only see about 6 results pop up. So this is what led us to conduct a systematic review of our own. This was published in 2024. And we can see on the right-hand side, these are all of the various search terms that we looked into to get an understanding of what exactly does concussion management look like for the performing arts student. And here are some of the findings that we came across. So there was a total of 18 studies that we kind of started out with at first. We removed any of the manuscripts or abstracts that didn't fit within our inclusion criteria. So they really had to be focused on the university performing arts student. It couldn't be a pediatric patient, for example. And we also removed some of the non-English publications. And really what this left us with was a nearly empty review. There really were only 2 articles, one of them being a case study and another one being a case series that fit within our inclusion criteria. We also found that it was really difficult to understand whether or not these individuals that were participating or highlighted in these studies, if they were specifically enrolled in the university setting or if they were just university age, which could also include some of the professional performing artists. Again, the systematic review kind of pairs nicely with even with the most recent PubMed search to, again, just highlight the lack of literature in this space and really a necessary growth for clinical management. So this led us to our current project, which we're really excited to share with you all today, and how we developed what we're calling the progressive return to performance protocol. So we took a group of individuals using what's called the Delphi procedure. It's a very common study strategy in sports medicine to develop clinical guidance, particularly in a topic where there really isn't a lot of literature in that space. So this would be a perfect topic for a Delphi study. And so within the panelist group, we had a group of clinicians who were working on university campuses and kind of familiar with the inner workings of campus life. We also included a variety of concussion researchers ranging from postdoctoral fellows all the way through tenured professors. We also wanted to make sure we included university academic counselors, as well as performing arts faculty and staff to get their perspective on how we could maybe address some of the barriers, not only to clinical management, but also some of that miscommunication that oftentimes occurs between our medical and academic teams when progressing students back into the classroom after concussion. And then most importantly was this small cohort of individuals who were either current or alumni students from these institutions who had actually sustained concussions during their performing arts training. And we found that it was really valuable to incorporate their voices and their experiences when we're developing these clinical guidelines. So in addition to generating some recommendations to support our dancers, music performers, and our thespians or those who are enrolled in theater and drama, we also had a subset of questions in terms of understanding what are the experiences and or barriers that some of our students are facing when seeking healthcare on campuses, and they're not protected under that nice NCAA model. So among our general population students. And so, really, what happens during the Delphi process is that it's completely anonymous. So, our panelists had no idea who was on the panel themselves. And they were provided a list of kind of open-ended questions. From there, the research group met and we kind of pared down all of the different responses and generated statements. So, this resulted in about 273 total statements after that first round. Following the second round, our panelists rated their statements on a scale of 1 to 9, 1 being not important at all, 9 being very important. And if there was a statement that achieved a 7 or lower, we removed that from the total statements. So this resulted in 180 statements, again, anonymously voted on by the panel. Following round two, there was only a couple statements that did not achieve consensus. Again, that was at that 7.0 threshold or lower, resulting in a total of 178 statements. So in addition to the protocol, again, we asked a variety of open-ended questions regarding some of the barriers to facilitating concussion education or clinical management within performing arts departments. And these were kind of the four main topics that came about. There was a variety of suggestions on how to improve concussion education topics or incorporate that within the performing arts, identifying some of the challenges in managing concussions in the arts, some of the barriers to seeking healthcare within this cohort, and then lastly, some ideas or strategies to improve support for our performing artists. In addition, we wanted to ask them, our Delphi panelists, what do you think about this return to sport progression as proposed by the International Concussion and Sport Group? And how can we maybe modify some of these recommendations to make it more specific for returning to dance, music performance, as well as theater and drama? So it followed a similar voting process that I had described before with those four kind of overarching themes, where they created statements based on the open-ended responses. Our panelists anonymously voted for them over 2 rounds, and then consensus was considered if these statements had met that 7.0 threshold. And this resulted in the progressive return to performance protocol. Now, this protocol is about to be under peer review, so we ask that you do not take any screenshots or photos of this protocol because it likely will go under several different iterations as we go through the peer review process. Briefly, I'm just going to go through each of the progressions. We can see on the left-hand side, this is going to mirror that return to sport strategy, starting with stage 1, symptom-limited activity, all the way through stage 6, which is going to be full clearance for return to performance. First, beginning with some of the return to dance Delphi recommendations. We are encouraging our students to avoid any activities that increase their symptoms, maybe sit in on class so long as that, again, does not increase their symptoms, especially if they are experiencing photo or phonophobia. As they move into that second stage, this is where we start to reintroduce some light aerobic exercise and then progress that forward depending on how they're feeling. So we offer some specific recommendations unique to the dance setting. And then moving into stage 3, this is going to be more individual discipline specific exercise. For our dancers, maybe this is reintroducing some exercises without the risk of head injury as well as inversions, increasing the time of completing aerobic exercise, marking choreography, and then starting to add movement with alternating directions to really perturb that vestibular system. Moving into our music performers, similarly with stage 1, avoiding any of those activities that increase symptoms. As they get into stage 2 with the light aerobic exercise, maybe they're progressing their scales or etudes up to about 20 minutes, maybe introducing a treadmill or a stationary cycle for 10 to 15-minute increments. By stage 3, again, this is that individual discipline-specific exercise. So this is increasing the performance, duration of their performance, practicing in low stimuli environments, again, removing some of those stimuli that can increase their symptoms, and then also engaging with individual lessons with the instructor. Among our theater students, we also want them, again, back at stage 1, to reduce that any activities that increase symptoms. However, we want to make sure that within all of these groups, our students are reintroducing social activities. We don't want them to be isolated because we see in the literature that oftentimes that can prolong their recoveries. By stage 2, similar to dance and music, they're going to be reintroduced to light aerobic exercise. We want to emphasize that there should be no jumps or turns or inversions at this stage. By stage 3, they'll be reintroducing some dance or musical theater specific activities that do not increase the risk for head injury, marking choreography, and increasing aerobic capacity. As you recall from Dr. Schuyten's section of the lecture, within the return to sport strategy, there is this small section above stage 4 that indicates students may not progress through the remainder of this protocol until they have complete resolution of symptoms, as well as any other cognitive or abnormalities or changes in clinical function, including with and after physical activity, which we have recommended throughout the different stages here. So if you do have a student that isn't progressing well or is having an increase in symptoms, more than 2 points on that 0 to 10 point scale, they may need to go back to the prior stage or stay there a little bit longer before they can move forward into the protocol. Among our dancers, they're going to begin more high intensity exercise. Then in stage 5, participate in some of those typical training activities, followed by resuming full return to performance in stage 6. So we want to be increasing their plyometric training, maybe starting to add more cognitive components as well as assessing confidence. As they progress into the later components of the protocol, we want to make sure we're restoring that confidence, particularly as they re-engage with partnering and lifts, because it puts other students at risk for injury. And then by stage 6, they should have complete resolution of any symptoms with and after exercise, and then also removal of any additional supports that might have been put in place during their recovery. Among our music performers, they're going to gradually be increasing that effort in their performances, maybe fully engaging in singing or playing during class activities. By stage 5, they're going to be reintroduced to more of those performance conditions, so the lighting or the amplification from the sound, and then building that endurance to typical show performance intensity before progressing into stage 6, which again is going to be full return to performance. And then among our theater students, this is going to be progressing them again further along into the performance-specific activity, restoring confidence, maybe working one-on-one with the instructor or working with a cohort of peers, and then reintroducing some of those high-risk activities before that full return to performance. Now, this protocol is not all-inclusive. There are a lot of other statements that also made the cut, but for presentation purposes, this is just kind of a snippet of the protocol. In terms of our future initiatives, so it's really important to think about how exactly will this be implemented or incorporated into clinical practice. So what we really like about this protocol is it kind of provides a nice framework for our medical and our academic teams to work together, particularly among medical teams who don't have expertise in the performing arts, as well as our academic teams who don't have expertise in concussion management. Importantly, performing artist disciplines are diverse and have very specific, unique demands, as Dr. Schuyten had briefly mentioned before. So it's really important that before we actually kind of roll this out into institutions of higher education, that we evaluate some of the implementation procedures to make sure that not only is this feasible in these settings, but also is it appropriate for the discipline and acceptable among our faculty and staff. So here I have an example of one of the implementation frameworks that we like to use. It's called the REAIM. It stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And there are several different strategies to evaluate the REAIM implementation framework in clinical practice. First one with Reach is understanding who is the target population. For our protocol specifically, this is going to be for our dancers, music performers, and then our theater students. The effectiveness. So how can we measure whether or not this protocol is effective compared to maybe other protocols such as the return to learn or the return to sport strategy? We also want to make sure that we are measuring the organizational support. So is there funding or additional resources or maybe even individuals who can help kind of spearhead these efforts to make sure that this protocol is implemented appropriately and as it should be, as well as adopted into practice. In terms of implementation, this is how the protocol would be delivered. So maybe incorporating some form of a cover letter or kind of a brief overview of the directions of how this framework could be used in practice is going to be key moving forward. And then lastly, maintenance. And this word just really represents the long-term implications or use. This could also kind of fall back into adoption in terms of organizational support. In other words, are there stakeholders involved or maybe additional resources to make sure that this protocol is implemented correctly and then can sustain over years and years. And another way that we can kind of think about implementation is through what's called the Bronfenbrenner's ecological framework. And this is a really interesting framework. It's used very often in clinical practice to understand the complexities of human development and how various different components of their environment can shape their individual life. So it's really emphasizing that the broader context of an individual's life can really influence some of these decision-making processes and not just their immediate circumstances. So this is the interaction between the individual or the performing artist themselves and then the other environmental factors that could influence some of these outcomes. This is really critical for us as researchers as well as clinicians to investigate further when we implement a new protocol or a new strategy, because we need to have an understanding of the barriers to implementation and or adoption as well as maintenance over time. Starting at the individual level, so this is going to be the performing arts student at the center. Surrounding them immediately is going to be what's called the microsystem. So this is going to be the immediate environment. This could be family, peers, maybe their learning environment, such as an instructor, a mentor, or a friend. So we know that individuals that are working peer-to-peer at the collegiate level, among other individuals who have sustained concussions, tend to do well in terms of seeking academic support, as well as how to kind of navigate the system within higher education. Above the microsystem, we have what's called the mesosystem. So this is the interaction between peers or school, as well as the family home environment, which could again influence the likelihood of whether or not to seek supports after concussion. Above the meso is the exosystem. So this indirectly influences the development of the self. This could be like institutional policy or governmental policies that could have a direct influence on the performing arts students, as well as maybe parental or guardian workplace if they have exposure to healthcare resources and whether or not that gets sent down through the pipeline to the students. We also have the macro system. These are kind of the overarching social structures. So the attitudes, beliefs, culture, and values of the performing arts students. They're going to have very unique demands compared to our other general population students or our non-athlete students that aren't necessarily accounted for within the current return to learn and return to sport strategies. So really we need to focus a lot of our work on this macro system and how we can incorporate more of our patients' beliefs and values to increase compliance. And then lastly, we have what's called the chronosystem. So this is how things start to evolve and change over time. The best example I can give is with concussion education. We're seeing that as we continue to advance concussion education strategies using different mass media to basically explain the consequences of not reporting concussions and some of those long-term outcomes has really demonstrated an increase in reporting among our patient populations. So this is really how our individual beliefs start to change over time, as well as just the influence of time and life periods, historical events, how that can all affect our decision-making process. And really what I wanted to end with this section is all of these are somewhat intertwined and it always comes back to the relationship back to the performing arts student. So as we think about future research strategies and thinking about some of the barriers to implementation, we really need to be thinking about these types of ecological frameworks and how there are several different interactions at play that can influence its uptake. I'm going to highlight some of the main takeaways from our lecture today. The first one being that there is a major cultural shift that is imperatively needed within the performing arts. We really are recommending our performing arts departments to consider mandating concussion education, similar to our NCAA coaches and student athletes, as well as those who work directly with our student athletes. We also want to strongly recommend safety plans at each performing site location, such as an emergency action plan. And then identify some of the barriers to concussion assessment, whether or not you have a medical personnel on site at all of your various performing environments, or if there is a central location, how our students are seeking treatment and how that might be able to be streamlined a little bit better, and then resources for more targeted rehabilitation. We know in the literature that individuals who seek targeted rehabilitation or individualized care tend to do much better in the long run. As we've mentioned before a few times in this talk, our performing arts students have very unique challenges when returning to their training or performance environments. A lot of these have yet to be considered in concussion management literature, as well as our consensus documents that guides clinical practice. So this is really highlighting a strong need for all of our concussion researchers and clinicians to band together to develop some more succinct guidelines. The progressive return to performance protocol can serve as a clinical framework for physical therapists as well as other interprofessional clinicians. It's not a legally binding document. This is something that is certainly flexible and can be modified based on the student's discipline. And then lastly, further research using some of those implementation-based frameworks that I discussed before is strongly needed to really understand what are the barriers to the protocol's adoption and then its maintenance over time. Thank you for the time to listen to our talk today. We are really, really excited about this work and the opportunity to share this with you all. If you have questions, you are welcome to reach out to myself or my colleagues. We have all of our contact information listed here. Thanks again.